It is a pleasure and an honor to introduce Fred Morady to give us grand rounds today. Fred is a living legend in electrophysiology. He's been at the University of Michigan for more than 30 years. He trained in UCSF in cardiology and EP, and then stayed as faculty there. And then he moved to Michigan. He has developed a leading program in EP for decades. And Fred is kind of a medical prodigy since almost childhood. He was telling me yesterday he started college with already 4 publications EP related. So he actually was in a picture at Cedars-Sinai where I trained, where they had this picture of former faculty that was back from the 70s or 60s, and you could see Swan and Gans and all the old legends, and then this young thin guy. And I go, who's that guy? And then PK Shah told me, well, that's Fred Morady. Like, well, as a high school student, he did research at Cedars and managed to publish before going to college. But that tells you what kind of a man he is, and we're delighted to have him. He's going to be talking to us about the management of atrial fibrillation, rate control versus rhythm control. Thank you, Fred.
Thank you very much, Miguel. That's one of the nice things about traveling and giving a lecture at a different institution. It's good for my self-confidence and ego. At home, everyone thinks I'm a horse's ass, so it's nice to hear nice comments. Now, I'd like to start off with a case presentation. A case that's fairly typical. It's not an unusual scenario. A 56-year-old woman who's undergoing a pre-op evaluation before shoulder surgery, and she's found to have atrial fibrillation. She, on history, says that she's had mild palpitations for a few weeks, but no other symptoms. She's got hypertension and very mild LVH on her echo, otherwise no evidence of ischemia. That's her electrocardiogram. So the question comes up, this woman who has very minimal symptoms, she really didn't, the symptoms were not severe or noticeable enough for her to go to see her doctor and tell the doctor that something was going on. So what's the best approach for this woman? Cardioversion plus a rhythm control drug, just keep her on a heart rate control strategy because her heart rate already seems to be pretty well controlled, or a more aggressive approach of catheter ablation. This is the one of the issues that I want to address today. The decision was made by her physicians to do cardioversion, so she underwent transthoracic cardioversion, and but she came back for follow-up 10 days later when she was back in atrial fib. So transthoracic cardioversion is a very simple choice. I mean, it's not a big deal. You're not initiating therapy with medications that might cause side effects or more serious adverse effects. So that's an easy decision, but it didn't work. So now it becomes a little tougher. Should you just leave her alone with heart rate control? Should you give her a rhythm control drug and do cardioversion again, or be more aggressive with catheter ablation? So her physicians put her on propafenone, and cardioversion was performed again. But a week later, she was still in sinus rhythm at 1 week, but at 6 weeks, she was back in atrial fib. So now there's an important fork in the road. At this point now, I mean, one could say, well, why not put her on amiodarone, which is more effective than propafenone? And I don't think that would be reasonable in a relatively young individual who has minimal symptoms. It wouldn't make sense to use a drug that can create organ toxicity. And generally speaking, when one rhythm control drug other than amiodarone doesn't work well, it's unlikely that the other ones will. And propafenone doesn't have any major side effects. A lot of the other rhythm control drugs do. So now the decision is heart rate control or catheter ablation. Now, the background of this whole controversy of rhythm control versus rate control was strongly influenced by the Affirm study, which was about 15 years ago. Large-scale study, but age greater than 65. Randomized to drug therapy, rhythm control drug plus cardioversion if necessary versus rate control. And at 5 years, 63% of the rhythm control patients were in sinus rhythm. But that means 37%, a large proportion, were still having atrial fib at that 5-year point. And that's not at all surprising, since most rhythm control drugs are not all or none. If they reduce the amount of atrial fibrillation by 60, 70, 80%, that's usually considered a very good response. But no significant difference in quality of life, stroke rate, or total mortality. And there were fewer hospitalizations in the rate control group than in the rhythm control group. And this shows the all-cause mortality. There was a trend towards lower mortality in the heart rate control group. So the conclusions of the Affirmed trial had a very strong influence on clinical practice at the time. The conclusion was that management of atrial fib with the rhythm control strategy offers no survival advantage over the rate control strategy, and there are potential advantages, such as a lower risk of adverse drug effects with the rate control strategy. So if we applied this to our 55-year-old woman, then it'd be a no-brainer. I mean, why not take advantage of the potential advantages of a heart rate control strategy? So this is what I want to go into in a little more detail. Now, first of all, there are limitations to the Affirm study. First of all, they were not comparing sinus rhythm and atrial fibrillation. You have to, that's a very basic concept that not everyone appreciates. No one is disputing that sinus rhythm is not better than atrial fib. I mean, who in their right mind would not rather be in sinus rhythm than atrial fib? There's a comparison of two strategies, and the strategy for rhythm control was very flawed. Rhythm control drugs don't work very well. Very important is it was an elderly population, age greater than 65, mean age was 71. And many patients had recurrent AF in the rhythm control group. And there were 3 other large, fairly large randomized trials which all had similar conclusions. But they all suffered from the fact that they were elderly patients and patients without severe symptoms. If they had severe symptoms, they weren't even enrolled in the Affirmed study. And there was clearly underrepresentation of paroxysmal atrial fib. Now, interestingly enough, a couple of years after the first, the indexed data where the study was published, they did a post-hoc analysis, the same investigators of the Affirmed data, and showed that there actually was a survival advantage of sinus rhythm. But it was completely wiped out by the increase in mortality associated with other factors such as antiarrhythmic drugs. Now let's look at some other mortality data. Unfortunately, at this point, we don't have high-quality prospective studies that can demonstrate improved survival with sinus rhythm. What we have are large population-based studies which have limitations, but I think the data are still important to take into consideration. This was a 26,000 patient study from Canada, and mortality was compared in patients treated with rate control drugs versus rhythm control drugs. They did a fairly good job in correcting for a lot of multiple confounding variables. And there was a lower mortality with rhythm control, but only after several years of therapy, which makes sense because if there's a survival advantage of sinus rhythm, it's not going to be huge. And so it's not going to be, it may not be apparent after 3 or 4 years, but after 7, 8, 9 years, that may become detectable. So obviously, if you're starting off at the age of 55, there's more opportunity for enjoying a survival benefit of sinus rhythm as compared to if you're 75 years old. This was a Swedish registry study, 272,000 patients with a case control design, mean of 14 years of follow-up. And this is a summary of their results. Under the age of 65, the relative risk of death in patients who had atrial fib compared to sinus rhythm was, the relative risk was 70% higher for men and more than twice as high for women. And as the age group became more advanced, for example, 75 to 85, then as you would expect, the mortality benefit is less apparent because it's a fact of life. As we get older, we're going to die from something. Now let's talk about the stroke risk. As you know, we use the CHADS-VASc risk stratification scheme now to quantitate risk and for clinical decision making. And this looks at the risk of stroke with rhythm control versus rate control in patients with atrial fib. Very large study. 59% were anticoagulated with warfarin. That sounds very low, but unfortunately, it's fairly typical of what's going on in community practice. And we thought that with the NOACs, the new oral anticoagulants, that there'd be a higher percentage of patients who qualified for anticoagulation would be anticoagulated. But studies as of the last year or two still show that there's significant underutilization of anticoagulants in patients with atrial fib. It may not be as high as 40%, but it's still in the range of 25 or 30%. Rhythm control therapy was independently associated with a 20% lower risk of stroke. It's a very different finding than the Affirmed study. And this looks at the stroke rates according to CHAT score. As you would expect, the higher risk patients had the largest difference in stroke rate. So that with the rate control strategy on the right side of the screen, you can see that the stroke rate per 100 person years is 2.9 versus 2.2 in the rhythm control group, and that's a significant difference. Another potentially deleterious effect of atrial fib is not only mortality and strokes, but it makes you dumber quicker, apparently. That's what these studies show. Two very recent studies, atrial fib. There are other studies from in the past few years. I've just limited to the two recent studies now. This is from November of 2015 in JAMA Neurology. 6,000 patients without baseline dementia, prospectively enrolled in a large study in the Netherlands, and 5% of patients had atrial fib at baseline. They screened patients for atrial fib and gave them testing for dementia every 3 to 4 years. If there was if the screening test showed possible dementia, then they did very formal neuropsychological testing. And during the course of the study, atrial fib developed as a first-time event in 12% of patients, and 15% developed dementia. Now look at the age group under 67, and our lady, the first case report she was 55. Follow-up time with atrial fib, and you can see the hazard ratio for dementia. There does seem to be a very significant higher risk of dementia in patients with atrial fib, presumably because of microemboli, even in the face of anticoagulation. And the effect the relationship between dementia and atrial fib was not apparent in the older age group, older than 67. This is a study published just a couple months ago online. It's not yet in print. And dementia in patients on warfarin for atrial fib versus other indications. You might think that the dementia that's related to atrial fib is maybe microbleeds from the anticoagulation. But that's not consistent with the data that we have available. And this is a retrospective analysis of more than 10,000 patients. The primary outcome of the study was dementia over 8 years of follow-up. And the dementia risk was related to the time in therapeutic range, which in community practices is often in the range of 70–75%. That when you have someone on warfarin, that the INR is reliably between 2 and 3. But across all the time in therapeutic ranges, the risk of dementia was higher in patients who had atrial fib than in patients who didn't have atrial fib, but were on anticoagulants for other reasons. And that was the case regardless of the specific type of dementia, just the general dementia, senile dementia, vascular dementia, or Alzheimer's. So I think that's something to keep in mind. Now, again, as of yet, we don't have any solid data that doing something about the atrial fib improves outcomes. We don't have prospective validation yet, but we have other sorts of data which, again, I think they're important enough to look at the evidence from these studies and to use as a guide for clinical practice. This was a study that was done in England, and it compared outcomes in 1,200 patients who underwent catheter ablation and had atrial fib, for atrial fib. And then they compared outcomes in patients with and without successful outcomes. They also had a historical control group of patients treated with medications. And they also looked at the general population of patients in the UK to compare outcomes. Efficacy was fairly typical of what you'd expect in a busy laboratory. 85% after, this is with repeat procedures if necessary, 85% for paroxysmal AF and 72% for persistent AF. That's the success rate. And this is the stroke-free survival in patients with and without recurrent AF. Significantly better stroke-free survival in the patients who had a successful outcome. There's a comparison of outcomes in patients in a control group of patients who were treated medically. Of course, this is not randomized, but there was a large difference in stroke or death on the right side of the slide. And then there were no differences between the ablation group and the general population in the UK in terms of stroke and death. So now we go back to our 55-year-old. If we sat down and had a discussion with her of the pros and cons of living with atrial fib versus undergoing catheter ablation. Of course, if she wanted to, she could have additional trials of rhythm control drugs. She hadn't been on flecainide, sotalol, Multac. There are other possible choices, but let's say none of those work well, and it boils down to catheter ablation versus a heart rate control strategy. I would not at all be swayed by the Affirm data. I don't think the Affirm data apply to someone who's 55 years old, like this woman who's very active. And so she opted for catheter ablation after we had a discussion of the pros and cons of living with it. And she ended up doing fine. But anyway, that's not to highlight the advantages of catheter ablation. The take-home message that I want to impart today is that there are a lot of advantages of sinus rhythm. No matter, whether you can achieve it with medication or by catheter ablation, it's clear that there are major advantages. Now let's move on to a second case, a 55-year-old man with persistent AF who has structural heart disease. He's had an MI, bypass surgery. He's had persistent AF for 6 months. And functional class heart failure, class 2 to 3 on the best available medical therapy. And he's got fairly good heart rate control at rest, 70, and when he walks around, it's in the mid-80s. Nuclear stress study shows a scar, but no ischemia. EF is about 30%. Echo, EF is about 30%. Left atrial diameter is 46. So what about this patient? Rhythm control, heart rate control, and with either one of those, should he also receive an ICD? Because he qualifies, strictly speaking, his EF is 30% or less, and he's got heart failure and coronary artery disease. So there was a heart failure version of the Affirmed study published in 2008. About 1,300 patients who had heart failure with AF, about half the patients who was ischemic in origin, the heart failure. Again, the mean age is 67%, mean EF 27%. Most of the patients, 2/3 had persistent AF, and they were randomized and followed for 3 years to rhythm control versus rate control. A very appropriate heart rate control targets, less than 80 at rest, less than 110 after 6 minutes of walking. No significant differences in cardiovascular mortality, all-cause mortality, stroke rate, or worsening heart failure. And so the conclusions were a rhythm control strategy does not improve outcomes compared to a rate control strategy in patients with atrial fib and heart failure. And this was very controversial. And even within the group of investigators, the Affirm investigators, there was not unanimous agreement with this. Because it's a very strong statement. And I think in a lot of patients, it's not true. And I want to show you why I say that. Again, keep in mind that a lot of patients in the rhythm control arm were still having atrial fib. A lot of the patients were on rhythm control drugs that had potential adverse effects, particularly in patients with reduced ejection fraction. And they didn't have hard objective endpoints. Well, they had mortality, but they didn't look at other things, the functional endpoints, such as ejection fraction, left ventricular dilatation, functional capacity. So we recommended treatment with amiodarone. We were consulted on this case. We recommended amiodarone for 6 weeks, and then cardioversion. 1 week later, he was back in atrial fib. Importantly, though, he said that he did feel like he had better effort tolerance for the first few days after the cardioversion. He had good heart rate control. I have an exam table in my clinic exam room, and I just have patients go up and down that one step for a minute. And if their heart rate is less than 120 after that, then I know they have pretty good heart rate control. That correlates pretty well with what you'd see on a Holter monitor. Because heart rate at rest doesn't mean much. It's fine if they're lying down or sitting and have a heart rate of 75. But it may be that when they do some exertion, it goes up to 130, 140, which would not be adequate. So anyway, at this point, he's on amiodarone. It hasn't worked. So it's either rate control, ablation, or either one of those with an ICD. Now, there was a very small study, unfortunately very small, but I think the results were very important. It was randomized, and the investigators compared catheter ablation with the ultimate heart rate control strategy. There's nothing better for someone with heart failure than AV node ablation and a BiV ICD. There's no more irregularity, there's no more uncontrolled rates. They have synchrony from the BiV pacing. So they followed for 6 months, and endpoints were ejection fraction, 6-minute walk test, and quality of life. And again, these are typical success rates at 6 months. So look at ejection fraction. With the heart rate control strategy, because these patients, most of them already had fairly good heart rate control, there was no improvement over the next 6 months. But look at the ablation group. Went from a mean of 27% to 35%. So their conclusion was that in patients with heart failure and atrial fib, catheter ablation of the AF results in better left ventricular functional capacity and quality of life. I didn't show you the functional capacity and quality of life, but they both significantly improved to a greater degree with ablation than with AV node ablation. So we did do an ablation procedure, and he went home taking 200 milligrams per day of amiodarone. At 3 months, he was still in sinus rhythm, and I had him stop taking the amiodarone. He had had a significant improvement in his effort tolerance, and his echocardiogram showed an EF of 40%, which is why we didn't initially implant an ICD. We anticipated the fact that it was very likely his ejection fraction would improve once we had him back in sinus rhythm. It wasn't going to normalize because he had the coronary artery disease and the scar, but it's very common that the ejection fraction improves 5 or 10%. So if it's kind of borderline in terms of qualifying for an ICD, you could buy some time by sending the patient home with a wearable defibrillator, a life vest, if you're worried about it. But this is not at all unusual that after a few weeks of sinus rhythm, the ejection fraction is significantly better. Sometimes you see it the next day in patients who have heart failure. The EF might be 25% before the procedure, and then 24 hours later it might be 32 or 33%. I gave him a 30-day monitor to wear at 6 months. There was no atrial fib. But I advised him to keep taking the warfarin because he had, because of his comorbidities, and because he didn't have any clear awareness of his atrial fib. He may have had a late recurrence of atrial fib and not been aware of it and ended up with a stroke. So this is not at all an unusual scenario in patients who have heart failure. There was another randomized trial of catheter versus rate control more recently in 2013. Unfortunately, again, a very small study. Patients had to have an EF less than 35%. The multi-procedure efficacy at 1 year was 92% in the ablation group. And they looked at VO2, quality of life, BNP levels, 6-minute walk, and ejection fraction. This is freedom from atrial fib over 12 months. Now this is the peak VO2. You see the functional capacity increases to in patients who've had catheter ablation compared to the control group, the heart rate control group. The BNP levels are significantly lower at 6 and 12 months in the catheter ablation group. And this is a change in ejection fraction. It improves to a greater degree by a mean of 10 percentage points in the ablation group versus 5% in the heart rate control group. There's no question that heart rate control will improve ejection fraction in patients who have an uncontrolled rate. But it's still not as good as sinus rhythm. Now, a very interesting finding in this particular study, this is now a different study published a couple of years ago, atrial fibrillation in patients with LV dysfunction. And what I was interested to see is an observation that many of us have made, is that even when there's excellent heart rate control in patients who have heart failure, the ejection fraction can improve fairly dramatically when sinus rhythm is restored. It's clearly independent of the rate. There are other factors in play. And in this study, there was an 8% rise in ejection fraction in these patients who started out with EFs less than 40%. And at 12 to 24 months, the improvement in ejection fraction was independent of the heart rate during atrial fib before the ablation was performed. So even when there's very good heart rate control, there are advantages in terms of left ventricular function. So I think that those kind of data support a more aggressive therapy in someone like this. Now, of course, it makes it easier if the patient tells you that he was feeling pretty well until about 6 months ago when he went into atrial fib. Then it makes it much easier to identify atrial fib as the culprit. But sometimes it's not so clear cut. And I think if the atrial fib is persistent and the patient has had a downward trend in their functional capacity, it's very often appropriate to try a rhythm control strategy. Now, on the other hand, it's clearly not appropriate for all patients with atrial fib and heart failure. If I see a patient in clinic who is known to have atrial fib for 5 or 10 years, and he's had heart failure, it's been relatively stable, I'm not going to advise a rhythm control strategy. First of all, it's not going to work anyway if it's atrial fib has been persistent for so many years. So in this, and this might be a little controversial among electrophysiologists. I don't know, would you have given him an ICD straight away? Or a life vest and wait? Or
it has the referring physician for a 6-month grace period.
Yeah. Yeah, I think that's appropriate. It very, very often works out that the patient ends up not needing the ICD. And if there is concern among the patient's other physicians, we can always send them home with a life vest until we have documentation of improvement in ejection fraction. And the last case I want to present is a 76-year-old man with persistent AF. This was discovered at a biannual exam with his primary care physician. No symptoms whatsoever. Very active, plays golf. Hasn't had any problems with his energy level. His only comorbidity is diabetes, and his heart rate is 95 beats per minute, irregular. He's on diabetes medication, aspirin, and his EKG shows atrial fib with an average rate of 95. He wore a 48-hour Holter monitor, had a mean rate of 105 with the atrial fib, and echo showed mild left atrial enlargement, normal left ventricular function, no ischemia on a nuclear stress study. This is a very appropriate patient for a heart rate control strategy. He falls into the Affirm type population. There's no evidence that we can improve his survival or cognitive decline or stroke rate by restoring sinus rhythm. It's going to be more of a hassle for him if he needs to be on a rhythm control drug. So I think that this is a case where heart rate control is very appropriate. Now, the last issue that I want to address is digoxin. His physician put him on warfarin and digoxin 0.25 milligrams a day. So the question is that a good thing to do? Is digoxin good for this patient or bad for this patient? And you may be aware of the fact that over the last several years there have been multiple studies that have addressed the impact of digoxin on mortality in patients with atrial fib. And they've gone both directions. It seems like every 6 months there's another meta-analysis that has a different conclusion. I want to show you 2 studies that were done that are fairly unique because they were both based on the same database, on the same post hoc analysis of the Affirmed data. 4,000 patients with atrial fib. This was noticed, published in the European Heart Journal in November 2012. And digoxin was independently associated with a 41% higher risk of death, regardless of heart failure status. Pretty dramatic. So now we have another publication in the European Heart Journal in April of 2013. Another, notice, post hoc analysis of the Affirmed database, exactly the same database. Conclusion, digoxin does not have a significant effect on mortality. Now, if you're not already a cynic and about post hoc analyses, then, I mean, this is the definitive evidence that we should have a large grain of salt whenever we look at post hoc analysis. They used different statistical techniques and had two completely different conclusions from the same database. But the fact of the matter is that if you look at the meta-analyses, there is probably more evidence that digoxin has a deleterious effect on mortality than otherwise. And so I don't use, first of all, it doesn't work very well as a heart rate control agent. And I had you notice that these are the two papers from the Affirmed study. And there's no fortunately, there's no overlap in the investigators. That would have been even more amazing if the same investigators were on both studies. But they are, I guess, two different camps within the Affirmed group. I don't know if they talk to each other or what, but now just for those of you who are into alternative therapies, non-traditional therapies, this has been advocated as a technique for atrial fib. If you can learn how to do this, apparently it has autonomic effects which limit or minimize the chance of developing atrial fibrillation. Now, in Michigan, we have our own brand of this. I want to show you. This is in Flint, Michigan, where we have a 30% unemployment rate. And they can't drink the water either. You may have heard that there's lead poisoning in the water, so they have other beverages. But I think, unfortunately, the alcohol probably outweighs the benefit of this yoga position. So we see a lot of patients from Flint who have atrial fibrillation. So I'm going to stop there, and I purposely left some time for questions, because even though you wouldn't think that rate control versus heart rate control is such a hot issue, but I find that it usually generates a lot of discussion and questions. So I'm going to stop there.
Thank you, Fred. That was a great overview. A couple of questions. I take rate control versus rhythm control as a starting strategy. In cases where there's a doubt, especially the heart failure patients, you may start with one strategy and see how well you can achieve rhythm control particularly. And then, like I told you, if I get 6 months of a grace period to see if the ejection fraction goes up, we may or may not do an ICD. How often do you see yourself switching strategies?
Yeah, well, sometimes the rhythm control strategy doesn't work. So obviously in those cases. But if we find that there's been no improvement, you raise a very important point, because if I see a patient at 3 months and they're still in sinus rhythm and they say they don't feel any better, their functional capacity is they don't feel any different than they did when they were in atrial fib, then if and when they have recurrent AF, we'll leave them alone. Just use heart rate control. That's also another interesting aspect of that, is that the value of doing transthoracic cardioversion as a test to see if sinus rhythm is beneficial for that patient's functional capacity or symptoms. Because it's not always clear-cut that the atrial fib is what's causing the fatigue or the shortness of breath. It may be someone who's very obese, who has lung disease, other reasons for, particularly in Michigan, my God, morbid obesity is rampant. And you have patients who have BMIs of 55 or 60. They come in the office and they're referred because their atrial fib is making them feel very, very tired. And I'm looking at them thinking, what are you talking about? How could they? Your BMI is 60. You're 300 pounds overweight. Is that really, you really think that sinus rhythm is going to make such a big difference? And, we don't like to do catheter ablation procedures in patients where you have to use a harpoon to find the femoral vein. And so we might do a cardioversion, and even hoping that they would have just a week or two of sinus rhythm, and use it as a diagnostic test to see whether or not they actually feel better. And lots of times they don't, which then allows me to just reassure them that it's not worthwhile to go through catheter ablation, because you're not going to feel any better from sinus rhythm.
About the data relating dementia and AFib, you showed that Jared Bunch recent paper on AFib versus other indications for anticoagulation, and showing that for patients on anticoagulation, those that had AFib had more dementia. So that kind of throws away the idea of bleeding, right?
Right.
So the idea would be that these patients have just subclinical embolic.
Yeah, that's what I was saying, that it seems likely that they have microemboli. I think that's the most plausible explanation. There was a great deal of concern about microbleeds from the anticoagulant, that it wasn't the atrial fib, it was just the anticoagulant. But that's why I showed the study from Bunch that was just published online. I think those are important data. It's pretty clearly not the anticoagulant. Yes?
Dr. Q, or you want to go first?
Thank you. Great talk, and I like the case-based, which I think is always very helpful to use. As we all know, all low EF are not created equal. And for an EF to improve after anything that we do, there have to be some muscle available to improve. So we see some of these people that are very dilated ventricles, thin walls, a lot of scar. No matter what you do, they probably are not going to get better. So my question is, are you aware of any studies where they're looking at other markers, either using MRI, volume measurements, anything else to try to dissect with those patients so that we don't invest a lot of efforts in trying to get them back to sinus rhythm and all that, just keep them in the medication and do whatever else we can for them? Because those ventricles usually, and we have anecdotally trying some of these people, and they just don't get better. I mean, they just very little muscle left to work with.
Yeah.
So are you aware of any studies where they have tried to use other markers?
Yes, both for atrial fib and for frequent PVCs. If delayed enhancement MRIs show a lot of scar, then it's unlikely that getting rid of very frequent PVCs or atrial fib is going to make any significant difference in ejection fraction.
I'm the endocrinologist in the room, and when I see amiodarone, of course, it raises red flags. But my question doesn't really relate to that. It's the cognitive issue, and to follow up with Miguel's comment. Could it be related to the flow causing the cognition, and has there been any studies to compare, say, a continuous flow LVAD, a non-pulsatile LVAD, to patients with chronic AFib in terms of their cognitive outcomes?
Interesting. No, I don't believe so.
I would like to address that the dementia and AF issue. Most of dementia really is Alzheimer's disease, and Alzheimer's disease is a tauopathy. So I don't know how you can say that a tauopathy has anything to do with atrial fibrillation. Certainly, the small percentage of people who have vascular or cerebrovascular dementia can be related to AF, but I would argue that what you're really talking about is true, and not causally related. That's number one. And I don't know that it has anything to do with flow. I think it's probably genetic and environmental rather than AF per se. There's also some dementia which is related to Parkinson's disease and these other things that are a synuclein type of a situation, and that has nothing to do with atrial fibrillation. So that's number one. Number two.
Well, let me address that. First
Yeah.
of all, I find it very plausible that there are other factors that could make Alzheimer's progress more quickly. Like you said, environmental factors, or there's probably almost certainly a genetic factor. But why would you think that small microemboli from atrial fib couldn't make it progress more quickly? I mean, I don't see any
Is there
reason
any?
that that's not-
Is there any autopsy? Is this creating edifices in
we
the
have these
clouds, or is there
observational-
autopsy evidence
No.
of that?
No, we have these observational studies. We don't.
All right.
There aren't any pathological.
Okay. My other issue is that when you say that digoxin and digitalis is not good at rate control, remember that digoxin is a very short-acting agent. In the old days, when we used DigLeaf, much before everybody in this room was born, we had pretty good rate control because it had Linnatus A, B, and C in it. Digoxin is C and not A. Nobody uses DigLeaf anymore because of all the other side effects of DigLeaf. But before calcium channel blockers and before beta blockers, you had pretty good rate control with DigLeaf.
Yeah, the problem with digoxin, though, is that it exerts its major influence on the AV node by increasing vagal tone, which is fine at rest. But if sympathetic activity increases during exertion, it doesn't work very well. I don't have data specific for digitalis leaf, but that's what the studies with different digoxin preparations have shown. And given the data that show a possible increase in mortality associated with it, I don't see a reason for using it. Well, that patient that I presented, I just took him off the digoxin and put him on 25 milligrams a day of a long-acting metoprolol succinate, and he did fine with that, and that also is good for his blood hypertension. But anyway, you still prescribe digoxin?
Well, I want to thank you for a really nice talk. For full disclosure, I'm actually the cardiac surgeon in the audience, and Miguel Valderrama will tell you that I just recently figured out the R wave was the one that went up. So I'll be very careful about any of my questions.
Well, sometimes it goes down.
Yeah, those are the bad ones.
Yeah, exactly.
So one comment and one question. The comment was, I really, like Miguel Canones, I really enjoy the case base, but all your patients were younger than me, so we should move to some older patients, please, sir. The one question is...
No, not that last patient was not
Yeah.
younger than you. I don't believe that.
I can't remember all of them, but I kept looking at them, and a lot of them
No,
were
the
younger
last
than
one
me.
was 75.
Yeah, that was the only one I think was older than me.
Well,
Everyone
don't
else
feel bad. Those first two were younger than me too.
Yeah. So the question is what do the MRs look like on these people that have persistent AFib and dementia? Do they look different? Do they have the diffusion-weighted lesions that we see after things like TAVR? My area of interest that kind of crosses over is TAVR, and we see 80% of these people come out with these diffusion-weighted lesions in their brain, which are areas of micro infarction of the brain. Most of them go away by 3 months, but a lot of us worry that we're just setting up something for dementia. If you look at the people with AFib and dementia and those that have AFib and no dementia, are the MRs different? Do we see these diffusion-weighted images, which we often see in people with dementia?
Yeah, I'm not. I haven't specifically looked in the neurological data, but I don't think there are any studies that have looked at that. I don't think so. Yeah. Well, that's also a concern after catheter ablation. There's several studies that have shown that asymptomatic cerebral lesions are fairly prevalent depending on the different types of catheters that are used. And their data showing that they go away by 3 or 6 months, and they have cognitive testing at 12 months that have shown no difference. But there is always that lingering concern is maybe it'll show up, the effects will show up a few years down the road. It's hard to know.
Morady, this is a really good talk. Actually, had a few comments and just one question. The first thing you mentioned, the irregular RR interval. So I did look into this. There are some animal experiments that looked exactly at that, and they looked at the irregular RR intervals in atrial fibrillation, and what they were able to find as regardless of the Frank-Starling mechanism, irregular heart rate was associated with some form of abnormal calcium handling, and that led to decreased contractility. So your point where you presented data that the improved ejection fraction does make sense based on some of these animal experiments that were done previously.
Yeah, we did a clinical study. We did a study in the EP lab probably 25 years ago, comparing cardiac outputs in patients who were being paced at 70 beats per minute in very regular pacing versus irregular pacing sequence, but the same average rate. And we found a 15 to 20% reduction in cardiac output.
Okay.
And this was just in the same patient lying down.
Okay.
So, yeah, there's definitely a deleterious effect of
Okay.
irregularity.
And then the other thing I wanted to just kind of, I guess, throw out is that it's not only the LV function, but there's data coming out in atrial fibrillation that it adversely affects RV function, and it causes severe tricuspid regurgitation over time. And actually restoring sinus rhythm, there's some studies that show that RV function improves over time based on what parameters you look, and also that tricuspid regurgitation goes away. So these are some of other things that can be associated with poor functional capacity in atrial fibrillation. And so I don't know if you've looked or come across
No, we
data
haven't
on-
looked at that, but there's no question that mitral insufficiency can improve when
Yeah.
sinus rhythm is restored also.
Okay. And then I had one question it's more relevant to people that we see in heart failure. People who have atrial fibrillation that's gone on for several years, is it worth a strategy at rhythm control with the ablation? Should we refer these type of patients, or it's basically the success rate? What is the success rate?
Yeah, and if it's been continuous, there haven't been any intervals of sinus rhythm, it's been continuous for more than 3 or 4 years, the success rate's going to go down. It's not impossible. I mean, it depends, and you have to make a clinical decision based on that patient's circumstances. How symptomatic are they? You know, is it really affecting their quality of life? And if it is, then we might do the procedure, and this is also the case if the atrium is very, very large, like 55 millimeters. But the patient has to know that it may take 3 or 4 procedures over the next couple of years before we can get sinus rhythm long term. It's not going to be a slam dunk.
Okay, I have one comment and a question. There's an Italian study, and this is the comment, and you didn't show this data, but I think it's kind of interesting, and I share it with people. The Italian study that shows that the IQs of patients with persistent and paroxysmal atrial fibrillation are lower than those that are in the control group that didn't have AFib. Are you familiar with that?
Yes.
Yeah. So anyway, you have a lower IQ. I suppose that could have something to do with dementia on down the road. But the question for you is, I'd just like to hear your thoughts on discontinuation of anticoagulation in the post-ablation patient, particularly one that may be undergoing long-term monitoring, longitudinal monitoring for AFib.
Well, if the patient doesn't have more than one comorbidity, and let's say we've done a catheter ablation procedure, or they're on a rhythm control drug, and they had symptomatic atrial fib to start with, and they seem to be doing well, then I very often give them the okay to come off the anticoagulant. If they have 2 or more risk factors, particularly if their atrial fib was not clearly apparent to that patient, you know, sometimes it comes on and it gradually over the next 2 or 3 weeks they get a reduction in effort tolerance, and they can't tell the moment it comes on. Those patients, we would be much more likely to advise them to remain on the anticoagulant indefinitely. Now, the whole thing is getting a little easier with these apps that are available where the patients can monitor their rhythm on a daily basis. And there's one device that the 2 electrodes are on their smartphones. And I've looked at that, and it's pretty accurate. And so, if that would give us a little extra assurance that we're not exposing the patient to a risk of stroke if they have a late recurrence, 18 months post-ablation or post-cardioversion. Yeah, that's another way to do it. Yes.
Thanks, Fred. For those of you who have never been to one, you can see why Dr. Morady's sessions at the EP board review courses are always standing room only. It's a pleasure to have you here. A few comments and a few questions. I think that your emphasis on atrial fibrillation as a complex disease process wherein physicians need to look at all the various factors that contribute to their symptoms is important. The individual you described is not uncommon in Houston with the BMI well over 40, with sleep apnea and hypertension and on a boatload of medications, and everybody thinks that curing their AFib, that's heart rate control, is going to make them feel better. And I want to emphasize that risk factor modification, weight loss, treatment of OSA, alcohol consumption reduction, et cetera, is an important part of evaluating and treating that AFib. The one quick question and then two other comments. Can you, or did they risk stratify the deaths in the antiarrhythmic drug arm in Affirm based on the type of drug? For instance, amiodarone versus all other drugs. And then two other questions. Can you comment on your feeling about AFib burden? And currently, the guidelines indicate that paroxysmal atrial fibrillation has the same stroke rate as persistent atrial fibrillation. There have been two device studies that I'm aware of that look at AFib episodes and what relate to risk of stroke, one by Medtronic and one by St. Jude. And then lastly, can you comment on the individual that has an isolated episode of AFib and comes to you a year later and their cardiologist still has them on digoxin and a warfarin or some other anticoagulant, but the patient has never had another clinical episode of AFib?
Well, your first point is a very important one about paroxysmal versus persistent AF and stroke risk. The majority of the data, not all the data, more recently there have been data in the other direction, but the majority of the data that we have available indicate that the stroke rate is as high with paroxysmal AF as it is with persistent AF. So the decision on whether or not to anticoagulate shouldn't be based on the amount of atrial fib that the patient's having. The device studies that you cited seem to show that even 6 minutes of atrial fib is associated with a higher risk of stroke. So it doesn't take a whole lot. And there was a nice study that was done by Dave Wilbur a few years ago that showed he induced atrial fib in the laboratory and showed that even after 10 minutes, he didn't have any sampling points before 10 minutes. He first sampled at 10 minutes and found that there were several procoagulant factors that were activated after only 10 minutes. It's not only the stagnation and the blood just swishing around in the atrium and causing the clot to form. The other factors also. So and that's important also because patients, first of all, a lot of patients with symptomatic atrial fib also have asymptomatic atrial fib. So they come back and they say, well, why can't I stop taking the anticoagulant? But they have hypertension and diabetes and 75 years old and have a history of an MI. And that's unwise because they very often, if you do event monitoring, patients with symptomatic atrial fib, you find very often they have asymptomatic episodes. They insist that they can always feel it. But then you have to tell them, yeah, but that's because you felt it. That's how you know. If you don't feel it, you wouldn't know that you had it. And some of them understand that, some don't. But anyway, so I think it's prudent to always anticoagulate whenever there's the possibility of atrial fib in patients who have multiple risk factors. And then what was the last point?
Well, the last point is that a patient referred to you that 18 months earlier had one episode of AFib, went to the ER, got admitted, was discharged home on a beta blocker,
And a NOAC.
Yeah.
And now they come to you, and again,
So after 18 months
yeah,
now.
let's just say they had several event recorders during the intervening 18 months. They don't have a link, but they come to you and they say, you know, I've never felt it. I don't know. And we all know
Yeah.
that they can have asymptomatic spells. How would you manage that patient? Would you do
But
that?
was the initial episode symptomatic?
Yes.
Yeah. Well, unless they have a lot of comorbidities, I tell them, yeah, stop taking it, and if you think it's come back, let us know right away. And that's another situation where the daily monitoring, self-monitoring at home could be useful. Yeah.
Your wonderful lecture. Thank you so much. I have a quick question. Sorry for my ignorance. I definitely need to overlook about the relationship between dementia and atrial fibrillation. But I have this question. Besides the primary causes or the primary theories about microemboli, microbleedings on the brain, is there any genetical causes or genetical research data, studies about the relationship between AFib and dementia?
No. No. Not that I'm aware of. I don't think so. No.